Hello, good afternoon. I'm Lorna Roll, the Chair of Neurobiology and Behavior, and we and the Swartz Foundation welcome you to the 14th annual Mind-Brain Lecture. This lecture series is sponsored by the Swartz Foundation, and we are all incredibly grateful for this ongoing support that allows us to get together, all of us who think about the brain at any time, and many of us who from the community who want to learn more. And I think this is going to be a really great opportunity for that. Today we have as our speaker Dr. Nicholas Schiff, who is the director of the Laboratory of Cognitive Neuromodulation at Cornell Medical School, which is now called Weill Cornell Medical College. I can't get these name changes straight. Dr. Schiff got his BA from Stanford University in 1987. With distinction, his MD from Weill Cornell Medical College in 1992, and that also was with honors in research. He trained with some very renowned scientists in the field, Drs. Fred Plum and Jerome Posner, and it is with these individuals that he co-authors a book, which is really, it's a textbook that is now essentially a classic. It's in its 4th printing on the diagnosis of coma and stupor. Dr. Schiff is an elected member of the American Neurological Association, and he's the recipient of a very impressive array of awards, and not the type that scientists usually get. I mean, in addition to the type that scientists usually get, he's also gotten named by Rolling Stone magazine as one of the 100 top people changing the scene of the United States of America, and by Time magazine in 2008 as one of the world's most influential individuals. Yeah. So it really is a special treat. In addition, a slightly more remote source, not quite as cool as Rolling Stone, the Society for Neuroscience, which is the world's largest organization of physicians and scientists who study the brain, gave Dr. Schiff an award a few years ago that is for innovation in neuroscience. And I think that you'll see just how innovative what he is doing is as he goes through his presentation. This work was in particular related to a breakthrough study that he published in Nature magazine, which was really the first rigorous evidence that deep brain stimulation could be potentially could initiate and perhaps even sustain recovery of consciousness in individuals who had been in a minimally conscious state. He continues to develop technologies and strategies to improve both the diagnostics and the treatment of cognitive disabilities that result from brain injury, and the title of his talk is Understanding the Recovery of Consciousness. Dr. Schiff.
Well, thank you for that very nice introduction, and I'd like to thank the Swartz Foundation and Dr. Swartz for the invitation to speak with you, and Dr. Roll in the Department of Neurobiology and Behavior here at Stony Brook for all the hard work that they've done sort of making this come together. In the next hour or so, what I'm going to do is take you through ongoing research that we're collectively engaged with colleagues both at Weill Cornell and at several places around the world, trying to understand better how people recover consciousness after severe brain injury, how we can understand how to measure using available technologies where their level of consciousness might be, and then to model our understanding of the biology of how people recover consciousness over time, and when they don't continue to recover, how we might understand that and when it might make sense to try and intervene, and then if we could, how we might do that. Before I go on, I do have a conflict disclosure just to mention. Some of the work at the end of the talk on brain stimulation has had partial industry support, and this is from a company that Cornell and the Cleveland Clinic developed to actually get that work started, and they continue to provide some support to me, and because I talk to them and tell them what I think, I'm a consultant and I need to disclose that. Here's the overview of what we're going to talk about. I'm going to start with trying to illustrate why we need to better understand mechanisms of recovery following severe brain injuries. And I'm going to show you a couple video clips that I think provide a very good case illustration of some of the issues. And then I'm going to go right into how we might start to see neuroimaging techniques, brain imaging studies, being used to understand outcomes following severe brain injury. And probably a lot of people, if they read the newspaper in the last month, were aware of a study by Monti et al. Where a MRI machine was used to communicate simple yes-no questions with a patient who couldn't otherwise show that they were aware. And actually, this is the continuation of an earlier study, which Adrian Owen and his colleagues had done. They were part of this Monti et al. Paper, and I'll explain that in some detail, but then show our own case studies using these types of methods, some variations on them, to really illustrate how hard this is going to be and how far we are really from being able to bring this kind of tool and assessment strategy into clinical practice, although it's going to happen. One of the things I think will help us as we go forward trying to understand these tools in this whole context is to develop a biological model for how consciousness recovers. And one of the surprising areas that we're getting information and insight into this general problem from is the phenomena that some patients who've had severe brain injuries have actually shown that they get better when they're given sleeping pills. And I will show you some data on what happens in the brain when a patient who recovers function taking sleeping pills, what that looks like, and then present a model as best I can to a general audience. And I'll try to use words that make things clear, but a lot of times the pictures will have some complexity that's kind of unavoidable, and I will do my best to convey the essence of this and sort of lead you into how, and this is not how we sort of arrived at it, but I think it's a good way of trying to understand it, how all of this information suggests that maybe some patients might actually respond to electrical stimulation of areas in the center of their brain called the central thalamus. And I'll take you through in detail a published study of one patient who we studied applying electrical stimulation and explain what happened as a result of that application of the technique. And then finally, I will close by pointing out some important limitations in addition to the ones I'll explain all the way through the talk about where we are and where we go forward. So let's start with the case illustration. And the case illustration I'd like to begin with is that of Don Herbert. Don Herbert was a firefighter in New York State. He ran into a building, and just as he got into the building, it collapsed. It was a 6-story structure, and he suffered a traumatic brain injury, but he also had a compression of the tube giving him oxygen, and so there was some element of him having a loss of oxygen as well. And when they found him at the scene, he went into a respiratory arrest. So he had a complex brain injury, had remained in a coma for a while, but then started to get better. And in fact, he got to the point where he could be stood up, he could walk a little bit, he could respond a little bit verbally. And then, for reasons that were unclear and then not really further investigated, he regressed. And he regressed into a state which I think you can see better from the images and the description of his family than I might actually describe to you. So let me just let them tell you in their own words.
You'd try to get them to squeeze your hand or move a toe or something like that. We were looking for just about anything.
Don Herbert did regain consciousness, but a few months later slipped into a minimally conscious state. He could respond to some stimuli, but was unable to communicate. Moved to a nursing home, he was kept alive by a feeding tube.
I took him to one neurologist, and I was basically begging him, to tell me, is he going to get better or isn't he? And he just sort of said, well, look at him. What do you see? You see what I see. There's nothing there. And I was just devastated.
So if we stop the story here, it would be a very common tale and actually enough to carry on the rest of the lecture, because certainly when I got into this, that was my impression of how we as professionals handled our assessment of this kind of problem, and it seemed as inadequate as I'm sure it seems hearing Mrs. Herbert tell this story. One would like to believe that there's a scientific model for whether somebody's going to recover consciousness, and one might guess that a family would ask, well, if they recovered after this initial injury and were getting better and then they got worse, why did they get worse? Can you explain that to me? Did it mean that they would always, stay this way? What about getting better? Unfortunately, that's not the state of the art yet. I think we're going to get there faster than I used to think. But for Don Herbert, 9 years passed, and then this happened.
Then one day, 2 years ago, the nursing home called with shocking news. Don had woken up and was asking for his family.
How long have I been gone?
One of the nurses lent the Herberts a video camera to record Don's incredible awakening. His first words were a struggle. He hadn't spoken in nearly a decade. Family members and buddies from the firehouse rushed to Don's room. Blinded in the accident, Don recognized everyone by their voice. Everyone, that is, except his youngest son, Nick, who was just 4 when his dad was injured.
That's Nick holding your right hand.
I'm right here.
Oh my God.
So the reason he says, oh my God, is that he puts his hand out here because he's anticipating that his 4-year-old son's head is going to be at this level. And this is a remarkable example. I've seen a lot of cases of late recovery. This is the most remarkable example that I know of, and it sets a calibration of our ignorance in some sense. It shows you how much preservation of latent potentiality could be present in an individual patient and go unrecognized, in this case, for a decade. And it raises lots of questions about how could this be, and how could we do better in pre-identifying patients who might harbor this capacity, and if they did, elicit this kind of response and recovery. And that's the topic of the talk today, and I'm going to sort of take you through what we're learning, what we know, what we don't know. I will come back towards the end of the talk and give you some speculations, and unfortunately they'll have to be speculations because we'll never exactly know what happened with Don Herbert, but I'll try to make a case that we have some idea of how this might happen. It's very interesting also to understand, in his case, which is different than most of the late recovery cases that I'm aware of, he had immediate insight into what he was being told. And this is the beginning of about a 4-hour videotape that a nurse gave the family a handheld video recorder, and this is all basically happening as he just comes out. So this is his initial recovery. And over this 4 hours, as he's asking his family, how long has he been gone, and they tell him it's been 10 years, he is in agony and distraught that he essentially feels that he's abandoned his family for this period of time. So the level of self-awareness, of reflection, it's kind of hard to imagine, and it's something I think that certainly challenges us to do a little bit better. So how do I think about it? How do we think about this kind of case? I think the best way to organize our understanding of disorders of consciousness is to recognize that you have to put cognitive function and motor function on sort of independent axes. And so here is a 2-dimensional diagram that puts total loss of cognitive function to the extreme left and normal cognitive function here over on the right. And then on the vertical axis, motor function, normal motor function here at the top, and total functional loss of motor function at the bottom. And the first thing one might notice is that as you span the range of cognitive function from total loss to normal function, there might be a problem in identifying patients who've completely lost cognitive function, and there are a couple diagnostic definitions that would encompass that. One is coma, and coma is by definition a condition in which patients don't show any ability to respond to their environment and don't change their level of apparent arousal. They don't have periods of eyes opening and eyes closing. And this is usually associated with acute brain injury and typically resolves after a couple weeks, unless patients get worse and they don't survive. And during that period of time when it resolves, the first thing to occur is that they start to have periods when their eyes open, and they sustain eye opening for some period of time during the day, and then their eyes close. And by definition, that's what a vegetative state is, and nothing more. So by definition, a vegetative state reflects, at least behaviorally, a patient who has periods of time when their eyes are open, other periods of time when their eyes are closed, and otherwise doesn't respond at all. The next step over from a vegetative state is something called the minimally conscious state, or MCS. And patients in the minimally conscious state show some definite awareness of their environment. And this could be as little as tracking a visual object as it moved across their visual space. It could be that they fixate or turn and look at people who come into the room. It could be that they follow a command to raise a thumb, or on the upper end of this the definition of minimally conscious state is functional communication. So patients may follow commands. If they can follow a command, you might be able to turn that into a yes or no response. And if you can turn it into a yes or no response, say, lift your thumb for yes and close your eye for no, then you could start to ask questions such as, am I pointing to the ceiling? Am I touching my nose? And right now, and I'm sure these criteria will evolve and they're already in flux, but right now, the boundary for functional communication is to be able to get 6 out of 6 simple situational questions correct, to not only generate a yes-no response, but that yes-no response should be accurate. Of course, this leaves a very wide range of cognitive levels between being able to do that and being fully recovered and able to do everything you could do cognitively before you were injured. That condition, when there is no capacity for goal-directed movement or very limited capacity, typically with eye movements or head movements preserved and nothing else, is what defines what's called the locked-in state. And people may be aware of the locked-in state from the movie The Diving Bell and the Butterfly as an example of this condition. And locked-in state has an asterisk here because it's not a disorder of consciousness. Consciousness and cognition are fully preserved. But from the point of view of looking at a patient in locked-in state, if it would happen that they didn't have a reliable motor channel, it might be, in fact, quite difficult to distinguish a locked-in patient from a minimally conscious state patient, or even a vegetative state patient. The reason I've drawn this box down here is that there might be ways, even without a reliable motor response, to identify that somebody was in minimally conscious state, as we'll see in a moment. But what we don't know now, and this is really important, and I'm going to illustrate this with some very specific cases in a moment, is actually if we have somebody who fits into this gray box, we actually have no way of knowing what the contents of their consciousness really are. You may believe, and I would like to believe, that we'll have tools that will allow us to kind of do this non-invasively with imaging, but we're not there yet, and I'm going to show you why it's a challenge. I think, just to get everybody oriented, probably most people recognize this image of the patient Terry Schiavo. Now, Terry Schiavo was in a vegetative state, and the underlying biological model for vegetative state is, and at least when it was defined, and the concept of vegetative state to sort of preserve its integrity, is that the brain above the level of the brainstem has lost too many neurons and too many connections to function. In Terry Schiavo's case, all of the data that was available to doctors looking at her over the period of time that she was alive was consistent with that being the case when she had her autopsy data reviewed. In fact, most of the brain cells, the neurons above the level of the brainstem, could not be identified anymore. Most of the structures no longer had neurons. However, clearly that biological model couldn't possibly be applied to Don Herbert, and what the biological model is that allowed a patient like Don Herbert to transition from this space to somewhere over here is really unclear, and that's where we're going. So, how might we figure out, without a motor response, that somebody was able to follow commands and at least respond to their environment the way a minimally conscious state person might show us by raising their left arm when we ask them to? Well, Adrian Owen and his colleagues at Cambridge came up with a very compelling and very clever way of doing this using magnetic resonance imaging. And they asked normal subjects to come in and do various mental imagery experiments. So they asked them to sit in an MRI scanner and imagine that they were playing tennis. And they found that that generated a very consistent brain activation in an area called the supplementary motor area, or the SMA. I'll mention that because it'll come up in the next several slides. And they also found that they could do other tasks, particularly having people imagine walking around their home, that generated different and spatially dissociated areas of brain activation so that they could have two kinds of different reporting from the brain when people didn't actually do anything except imagine. And in looking at patients, they found a single patient who clinically appeared to be in vegetative state, who, when they asked them to do these imaging tasks, mental imagery tasks, actually generated brain images that looked identical to the normal subject. So you just have to convince yourself that this pretty much looks like this, and this pretty much looks like that. And to a professional's eye, and to measurement, and to other more quantitative assessments, it turns out that is exactly the case. Now, what does it mean? Well, it's actually not that clear what it means. It at least means that the person was able to follow these commands, which would certainly take them out of vegetative state and put them into minimally conscious state. But actually, it might raise your suspicions, as I think it raises most people's suspicions, that maybe their cognitive level is actually quite a bit better than that. But we don't know. And what if you could turn this into a yes-no communication system? What if you could ask them to imagine doing one task to say yes, and imagine doing another task to say no? That theoretical possibility was prefigured in this result, which was the basis then for the new study that came out just a few weeks ago in the New England Journal of Medicine from the Cambridge group and the group collaborating with them in Liège, Belgium. And here is a normal subject doing the same two tasks, being asked questions. Do you have any brothers? Yes response with motor imagery. No response. Do you have any sisters? No response with spatial imagery. What these investigators were able to do was identify a single patient who, despite having no evidence of being able to follow commands or communicate at the bedside, and who had remained in this state for 5 years. Is your father's name Alexander? Yes. Is your father's name Thomas? No. They were able to find 5 examples out of 6 questions asked with no response on the 6th question that were accurate and transmitted to them by this method. And you may say, great, now we know how to deal with this, but actually we don't. And that's why this is going to be hard, and I'll show you in a minute why I'm saying this. But it might be pointed out that we don't actually know why the patient didn't respond to the 6th question. And we also might point out that this method won't, in principle, allow a patient to interject and say, yes, but. His name is Alexander, but he goes by his middle name. And it doesn't help us understand what to do if the next time we bring this patient into the MRI scanner and they're a little drowsy, or it's not a great day for them, and we get no response. How do we start to sort this out, and how do we deal with this lack of motor channel? Well, so we, a few years ago, because we collaborate with Dr. Owen and Dr. Lories as well, began our own studies, and we were interested in a couple things, and this is work done with Henning Voss and John Barden at Cornell. And John Barden's a graduate student, and he had been reading the Bowlby book, Diving Bell and the Butterfly, and we'd had several locked-in patients come through our research program, and the most sort of immediate thing you recognize is how effortful it is to communicate when you have a slow, limited communication channel, and the frustration of patients who are fully conscious trying to get their message out. And often they're working with letter boards and head movements or eye movements, and they go line by line, and it's a yes, no, this line, that line, that line, and then they go through the letters in one particular row to try to get to the letter. And as you write the letters on the letter board, the patients always want you to guess, to fill in the words so that they don't have to do the effort of spelling out the entire sentence line by line. So John said, well, why don't we, instead of having this very complicated task where we have to have 2 different mental imagery responses and the patients have to remember a yes and a no, and then they have to figure out what question we're asking them and to match this all together, give them one response, just use one motor image, and start to build multiple choice questions so that we can use this, the way we ask the questions and design the experiment to disambiguate what their response might be. So we began with a different motor image. Instead of playing tennis, we did swimming because our index case was a patient who swam. And we found that if you put lab members and other normal subjects into the scanner, it's very, very easy to do this. You or I go into the scanner, we do this right away with the instructions. the signal is so strong you can read it off of the monitor and you can do this in real time. That's not the case for any of the patients that were published in the New England Journal. That's generally not the case for any of the patients we've looked at. If you do a fairly complex task, like show a subject one card out of the playing card face cards and ask them to swim or do their favorite motor activity to indicate the suit of their card, whether it's club, diamond, heart, or spade, or the face of their card, ace, jack, king, or queen, it's actually 100% reliable and extremely easy to do. And here's one of our normal subjects doing this task. So the patient that we first were concerned about and wanted to investigate was a young woman who was 22 years old who had had what's called an idiopathic etiology. That means we don't know why this happened, of a collapse or an occlusion of one of the large arteries, the basilar artery that comes up the front of the brainstem. And what you see here is actually a mechanical shunt that's been placed into the basilar artery. And this artery had completely occluded. And what's missing in this patient's brain image, this is the lower brainstem, this is the medulla and the cervical spinal cord and the ventral part of the pons. And what's missing in here is the rest of the structure. All of the brainstem above this region in the center has been replaced by spinal fluid, as has the midbrain and many of the structures going up. As you see here in a more lateral view, there is preservation as you move out laterally, but this is the, for those who are schooled in neuroanatomy, this is the superior and inferior colliculus. This is the quadrigeminal plate sitting on top. So this is a very large injury to her brainstem that included damage in the thalami, which are the structures in the center of the brain that connect to the cerebral cortex. And this part of her injury is an injury that's associated with locked-in state. This is the kind of injury that Bowlby, the man who wrote Diving Bell and the Butterfly, had. However, as this injury involves more posterior structures, areas in the back here, and going up, it's also known to be associated with problems in consciousness and staying awake. And this patient had carried the diagnosis for 2 years before we saw them of vegetative state, although one very careful exam had noted that there was some ability for her to move her eye up and down. And we had an opportunity to examine this patient over a week, and the first day that we examined her, we found no evidence of anything other than vegetative state. But during one exam on the next day, when she appeared much more alert than she had, it was found that she could occasionally look down to command using only one eye. And by the end of that day, in the evening, when she had a spontaneous change in her level of arousal and was much more alert, at least judged by the degree of eye opening, we had inconsistent ability to do yes-no communication with her eye. So we made these observations, and the patient's family and the people taking care of the patient got to see them, and the patient went off and started having speech therapy and lots of different types of interactions while we worked on getting these paradigms together, and brought her back about 8 months later when she was most of the time able to do some movement to command with the eye by 8 months after that. And we were able to generate evidence that she could do the motor imaging task, and again, doing swimming, not tennis, but it's the same area of the brain. And we tried the communication paradigm. And this patient's card was the ace of spades. And what you see here, I think, is part of the reason I think that it's going to become very difficult, and we're going to require a lot of effort to put together these technologies to understand sort of where people are at. So what we got in response in her brain was a response to club and a response to ace and a very clear response to jack. And we were able to get this on a retest. But that wasn't her card. Now, her card was one of the black cards, and we know that she might have had some visual problems, and maybe she couldn't resolve ace versus club. But we couldn't understand jack. And one of the other problems that happens with these kinds of injuries, particularly the injuries in the center of her brain, is that sometimes when you have a patient with just those little injuries, they're able to do all the things that you ask them to do, but it happens at a delay of maybe 20 to 30 seconds. And as it turns out, if you look at this, that may be what's going on. Because when we look at the brain responses of our normal subjects, we see that they have a typical shape and a starting point. But in our clinical subject that I just described, this response pattern actually looks different, and it has a peak toward the end. And this is actually something that the Owen and Monty group have seen as well. And what we don't know, but we are wondering, is whether what we're looking at here is a delayed response to ACE appearing as a response to JAK. But we don't know. And I think this gives you an idea of what this might be like in practice. And it's not going to be that if we have a patient who has a motor response that's inconsistent and we're not sure about, that we're simply going to go to an MRI machine, carry out these measurements today. Maybe in the future we're going to get better at it and it's going to become clear how to put all this together. But know even how to interpret what is clearly an attempt to use this mental imagery. She can do it. She can do it when we ask her to follow the command, and she's trying to communicate within the structure that we're presenting, but we aren't able to communicate accurately. However, this does show what we would call communication readiness. And I think it's fairly obvious that a patient who could do this and where we have all this sort of intuition that there's a there, that there's an intact cognitive state that we may not be able to measure and access, that we should be making lots and lots of effort to try to connect with them. And that's why I think there's an urgency to do this work, as well as obviously it's of scientific interest and it's fascinating. But here's the flip side, and I show this is maybe of more impact for the clinicians in the audience, but it's really important, I think. Here's another patient who we've studied. This is a 27-year-old male, and he suffered what's called a severe diffuse axonal injury. That means that the axons, the white matter connections in his brain, had been broken, in this case, as it often is in a car accident, where he had a T-bone injury. His car was hit by another car coming in an intersection, and it was spun. And when that happens, the brainstem often has a very severe injury, as was the case in this man's brain. But also, areas all over the brain get disconnected, and as you can see, well, for those in the audience who are aware of this, this is a very large filling in of the ventricular space in the lateral ventricles, in the center of the brain, in the back of the brain, all suggesting that there were many connections across the brain diffusely injured. And this man had remained in a vegetative state for 3 months, and at 6 months, the family had noticed that sometimes he could fixate his gaze. And he also had been noted to have some head movements to command. And in the first year of his recovery, there was a debate ongoing as to whether he really was following commands with his head. And the family said that there was one therapist who worked very, very hard with them, became convinced that he could respond accurately, and was the only person to kind of push the issue of trying to interact with this patient. Well, we did the imaging studies and found that he could do this, but it was kind of a foregone conclusion in some ways, because his head movements were good enough that he could use a letterboard and he could communicate with us. And he could, at the end of a couple hours of doing stuff with our therapy team, our research team, spell out on the board, "Get out," because he had had enough. But what he couldn't do at the time that we saw him was work through a communication device to reliably interact with his environment. And his family had been given the opportunity for a 12-week use of a head mouse paid for by Medicaid, but it came with a broken USB port, not a big problem technically, but they couldn't get them to pay for the person to come to fix it. So 6 weeks had elapsed, and he hadn't been able to try it. One of our enterprising medical students found a webcam that was free and hooked him up. And by the time a year elapsed from these studies, this patient is now able to initiate communication using his own simple assistive device. He's on the web, he sent emails to our research team, and he communicates his daily needs now efficiently and effectively. But Had he not been able to actually express motor behavior, most clinicians, if given these two patients and told one of them in a year is going to be efficiently communicating with a communication device, the other one, we're not going to really be able to show that they're really fully conscious, he would have been assumed, I think, to not be conscious. And this is the challenge here. We've got to move away from our gut intuitions based on structural images and things that really don't tell us anything to a biological model and measurements that really help us accurately calibrate our understanding of individual patients and then think about what we're going to do. So I think one of the most important things in moving in that direction is to have a biologically based model for recovery and understanding some of the ways in which the brain may end up in a relatively quiet state, as we saw Don Herbert persist in for 9 years, and yet have the potentiality of moving into a different state where the kinds of behaviors that would allow fluent communication and re-engagement could occur. And probably one of the most remarkable windows into this are cases where patients have recovered function when given the sleeping pill Ambien. So in 2007, a very interesting case was published in the Journal Annals of Neurology of a woman who had remained in the minimally conscious state following a severe hypoxic injury. That means that she had reduced oxygen to her brain. And in this condition, she remained unable to communicate for, I think, about 2 or 3 years at the time that this was done. She occasionally followed some commands. She could mouth occasional words, but she couldn't chew, eat, or swallow, and she couldn't walk. She was fed by a tube in her stomach. And for some reason, somebody decided that she was not sleeping well, and they prescribed Ambien. And when given 10 milligrams of Ambien, zolpidem is the generic name for the drug, she was noted to start speaking, that she could be given food, chew and swallow it without choking on it, and she could be stood up and she could walk. Now, this was not the first example of this, and this in itself wasn't necessarily surprising, but what was extremely important about this study was that the investigators then went on to measure her brain function on and off the drug. And this was one of the first examples of assessing what happens in the brain on and off the drug Ambien. And what they found in this patient was that when she was not on the drug, and this is the front of the brain, this is the back of the brain, we're looking at what's called a horizontal cut, so it's in this direction. And what should be the case is that everything should be roughly red and maybe more pink in the back, kind of like what you see back here. In fact, what you see is that the front of the brain and these areas in the center called the thalamus are not showing metabolism or brain energy usage when she's not on the drug. And when she's given the drug, they remarkably fill in their activity, and these are just two cuts showing slightly different levels in the brain. And this is a very interesting picture. And we were lucky about a month or two after this paper published that we had an opportunity to study a patient with a very similar kind of response at Cornell. And this was a patient who also had been known to respond to Ambien. This was one of the patients that actually had been reported a couple years earlier in the media. And he had been a victim of a near drowning. His car went into a ditch and the car filled with water, and he suffered another type of hypoxic or low oxygen injury about 9 years before we had studied him. 2 years after his injury, he had remained in a minimally conscious state, and he had an ongoing tremor and tended to moan at night. And what had happened was his family was going on a trip, and they were staying overnight at a motel, and they wanted to make sure that they were sleeping at night. So his mom got a prescription for Ambien. She gave the patient, whose name I can tell you because he's a public figure, his name is George Melendez. She gave George this Ambien pill to go to sleep. He seemed to quiet. She thought, great, this is sort of what I'd hoped was going to happen. And then she looked up, and she noticed that he was eyes open, looking all around the room, making lots of head and eye movements. And she said, George. And he turned to her and said, what? and you know, this was a big deal because he hadn't spoken in 2 years. And if you go on the 60 Minutes website, you can actually see the video that she took at the time this occurred. And he had been on Ambien for 5 years. since that every day, several times a day, and by the time we saw him off the drug, he was able to communicate, he was not in the minimally conscious state, he had trouble speaking fluently, he was cognitively slowed, and he had an ongoing tremor and what's called a dystonic posturing of his hand. He couldn't use it properly to do careful movements. Interestingly, his brain showed the same pattern. Now, I've confused you maybe a little bit because instead of looking this way at the brain, we're looking this way. This is now the front of the brain. This is the back of the brain. And as you see, the front of the brain is yellow, and these structures in the center are yellow. And when he's off the drug, this is what he looks like. But when he goes back on the drug, you see that, like the other patient I just showed you, all these structures fill in. In fact, there's a multiplier between the overall global metabolic rate in the off state and the on state of 1.97, which means, in simpler terms, on and off his brain, he doubles his cerebral energy use, which is a very, very big change. And when this happens, he can, in fact, chew, swallow, and eat on his own. He has smooth goal-directed movements, and he was a baseball pitcher, he can pick up and show you knuckleballs and curved balls and throw them out to you. And I think this is a very interesting phenomena and one that's giving us some insight into what might be going on in patients like Don Herbert, how this system could be maintaining a low rate. Now, he, unlike the other patient, isn't in a minimally conscious state in this off state, yet this abnormality in resting brain metabolism is still present, and yet when it turns on, the whole brain goes up quite a bit. We've been studying several aspects of this, and I'm not going to spend a lot of time on it because it's a little hard for a general audience, but one of the ways to look at this, not just from brain metabolism, is to look at the electrical activity of the brain, because the electrical activity of the brain is an important window on this. And this is what the electrical activity of his brain looks like when he's off the drug, and this is called an EEG, and these are samples of electrical activity over different electrodes on the head, and this is not something that even for a neurological audience people are easily able to do if they haven't been, to read if they haven't been trained in it. But just to point out, you can see that there are these sort of waves, and they're slow, and they're kind of the same on many of the channels, and they run up and down the trace. And I don't think you need to be an expert in this to look at this and then hold your attention on it. I'll show you what he looks like when he goes on the drug. You see, this all flattens out, and it becomes faster and more flattened across all of the channels, and this looks more like a normal EEG. So we've been interested in trying to understand kind of how all these changes go together, and one can kind of organize all of this information using tools of mathematics to kind of take that picture that I just showed you with those slow waves, which are represented here by this big blue peak, and see how they go away when he's given the drug, and the background activity of that set of brain waves gets replaced by higher frequency activity, here represented by this red peak. And in fact, we found that that kind of finding has been common in 3 different patients who have this kind of response. And what's very interesting in discovering that is that the 3 different patients have completely different types of brain injury. So the 2 patients I just talked to you about had hypoxic injury or loss of oxygen, just like Don Herbert had, probably combined with traumatic injury. We've seen patients with traumatic brain injury and with stroke who respond to Ambien who also show this kind of change. And it suggests that maybe the right way to think about severe brain injury and fluctuations in behavioral response is that they're probably common circuit level, which means things that happen because of the kinds of cells that the brain is made up of, how they connect to each other, and how they typically fail when things like severe brain injury reduce the level maybe of activity all over the brain. And that's what we've been working on, and we've been trying to develop what we're calling here a mesocircuit model for recovery of consciousness by trying to understand how to organize these responses. So the thing that I showed you, the images I showed you made the point that the front part of the brain downregulates or loses its metabolic signal in the off-drug state. And it turns out, and this is a very complicated diagram that I think probably I should have foregone, but I'll try to explain why I put it in here, that it turns out that the parts of the brain in the front of the brain are a little different than the rest of the brain because they have 3 sections of brain cells that sort of work like this. There's a connection between the outer part of the brain, the cortex, and the thalamus, the structure in the center, that has 2 sets of brain cells between it, and they're set up to do the following thing. They're set up so that this part of it keeps the outflow from the central part of the brain, the thalamus, from releasing its activation. And the way it does that is it constantly suppresses it or inhibits it. And it's released when the cortex can apply enough background pressure on this part of the brain to inhibit this inhibitory influence, which, as you see here, suppresses it and therefore releases this area. And to make this a little simpler, it turns out that if we think about the picture I just showed you as involving these parts of the brain, that if you were to release this inhibition, you could activate the central thalamus, which would activate the frontal cortex and activate this area called the striatum, and return maybe a flow of activation in this front part of the brain that could account for the overall increase in brain energy use and brain activity that I showed you, measuring both the brain metabolism and the electrical waves. And one of the things that's interesting in this model is it accounts for a lot of things that we know about the use of drugs in severe brain injury. So one of the things we know is that many patients respond to drugs that work on the dopamine system. So one of these drugs is a drug called L-DOPA. People are probably familiar with Oliver Sacks's Awakening stories. That was the drug L-DOPA. There are other drugs, amantadine is one of them, that work on the dopamine system. And it's known that giving many brain injured patients, whether they've had strokes or traumatic brain injuries, dopamine type medications can often elicit behavioral improvements similar to some of what we were talking about and I've shown you today. And we know that dopamine works on the frontal cortex, but also particularly works on this part of the brain called the striatum that's between the frontal cortex and the thalamus, to allow this release of inhibition so that this chronic inhibition here can be inhibited and then release the activity of this area called the central thalamus. How would we understand Ambien? Well, one of the possibilities, and we think this is an important part of it, is that it turns out that Ambien is a very selective drug agent that activates receptors for something called the GABA-A receptor. It activates the GABA-A receptor, which is what could be activated by these striatal inhibition inputs to the globus pallidus. And it could be that Ambien binds or takes its action here in the globus pallidus, releasing this inhibition that might be excessive to allow the increased activity coming out of the central thalamus. And finally, since in this model that I'm proposing to you, this structure, the central thalamus, was in both cases being released by these various manipulations, it might be possible, or might theoretically be possible, to simply activate these cells directly, say using electrical stimulation, to achieve a similar effect. So at least this is a thumbnail sketch. It's a simplistic model, but it actually looks like it could account for several observations. So one thing we know, for example, is that metabolism or brain energy use in the brain actually does correlate with level of recovery, and people have found that this same area that I showed you was chronically reduced in its activity in the frontal parts of the brain and the thalamus in the patients we just reviewed. Actually, over many patients, the degree of loss of metabolic activity in this area of the brain correlates with whether they recover with moderate disability, recover to a level of minimally conscious state, or recover to the level of vegetative state. This area of the central thalamus, it turns out, is associated with diffuse brain injury, and as you lose more and more cells from the central thalamus, your level of recovery can be correlated from moderate disability to vegetative state. And similarly, and this is well known to the neurologists in the audience, these areas in the central thalamus are the only areas that when you get bilateral injuries produce an acute coma. So this sort of kind of makes sense, and it also makes sense from the point of view of evolution, because the cells that come out of the brainstem that allow us to turn on our sleep and wake patterns have in fact selectively evolved to innervate, which means to attach and to deploy their synaptic contents in the central thalamus. And these are representations of the cholinergic system in the human thalamus coming from brainstem and basal forebrain regions. And this is the system that turns on during wakefulness, as well as the noradrenergic system. And both of these systems are selectively innervating or deploying their synaptic contents in the central thalamus. And the anatomy of this region makes sense with the picture I just showed you, because there's a tendency for most of these areas in the central thalamus to project strongly or to connect strongly to the striatum, the frontal systems that we saw activated, but also have very wide projections across the brain so that they would be positioned effectively to upregulate and turn on the brain, essentially waking it up even within a wakeful state. And in fact, if you study changes in normal subjects manipulating their level of attention during wakefulness, this is what you see, is that areas, and these are slightly different areas in the brainstem that also go into the central thalamus, are the ones that turn on as you focus your attention on a task, say coming to a red light, stopping and waiting for it to turn green. In that period, while you're paying attention carefully and waiting to release your foot from the brake, these areas are the ones that change their activity, and that correlates with activity levels across the brain. Similarly, people have studied when you're doing something like an air traffic controller would do, which is pay attention to a boring task, but it's very important, carefully over a long period of time. As you get worse at that task, you lose blood flow and signal, metabolic signal in these areas of the brain. And it turns out that if you look across lots of transitions from sleep to wake, transitions across different levels of anesthesia, or other manipulations similar to this of attention, that these areas in the central thalamus really become the main reporting areas for changes in the state of the system. So what do we know about Don Herbert, and what do we think might have gone on with him? Well, it turned out that Don Herbert was taken to a facility where he unfortunately had a fall, and he started to reduce his level of function. And as he started to reduce his level of function, his wife actually had the presence of mind to decide to go out to an outpatient PET facility and get him a scan. And she found, when she got him his PET scan, this image. And if you look at it carefully, I think what you can see is that this doesn't have the loss of the frontal metabolic signal that was seen, say, in this patient, but it does appear to have the reduction of thalamic metabolism here. And it turns out that Don Herbert's recovery wasn't spontaneous. It was several weeks after a physician in his facility had decided, why don't we try something? And so what they tried was a cocktail of L-Dopa, one of these dopamine agents, and two other types of medications, a serotonergic and a noradrenergic drug, all of which have converging inputs into this circuit, into the central thalamus. Now, we don't know that that's why he got better, and we'll never know, but it has some face validity. And the overall story, and it may be a just so story that I've kind of unraveled here for you, but I think it's a little bit better than that, suggests that there are testable hypotheses that we can organize to look at these cases, these very surprising sorts of events, and do a little bit better at thinking through how we could systematically maybe assess what's happening as patients recover, introduce pharmacologic agents over time or for limited periods of time to see if there are improvements, and then things that we might measure that don't depend on brain behavior relationships, but actually brain physiology, however we might measure it, to track whether these interventions actually are having an effect. So finally, in just a couple minutes that I have left, I'm probably going to run a moment over, I want to show you the final piece of this, which is the other prediction. What if you actually put electrodes in the central thalamus as a final common pathway in a patient who didn't respond? What do you see? Would you see anything? So we've been engaged in pilot clinical studies of central thalamic brain stimulation for patients in minimally conscious state with colleagues at the JFK Johnson Rehab Center and the Cleveland Clinic. And when we began this work, we thought a lot about where you would begin. And one of my colleagues, Joe Finns, who's an ethicist at Cornell, made a very good point to us because we had a lot of ideas and we thought, well, think about all these interesting scientific motivations and rationales for what we might do. And he said, look, of course, we don't know that this would work. And there's a long history of data that showed that it didn't work in vegetative state, in similar structures. And so we spent a lot of time thinking about where would we want to try this, where we could minimize the risk to patients, because as I just showed you, if you structurally injure these central thalamic targets, you'll actually produce these disorders. So you don't want to expose somebody to that risk without some possibility of benefit. And what would the right possibility of benefit be? And so we thought hard about this, and we thought that possibility of benefit should be to restore functional communication at this limited level of potentially moving past MCS that we began this discussion with, and that we should talk to regulators and local institutional review boards and try and get a consensus, which we did, and people thought this was reasonable. And we came down with these criteria, that we would start with patients who had these elements of the minimally conscious state diagnosis, that they could follow commands or show some intelligible verbalization or intermittently communicate. And we also didn't want them to have been in this condition for any less than a year, and they needed to show us by quantitative and careful measurement that they weren't recovering on their own. We developed behavioral scales and a scientific structure with a crossover design and a mechanism so that the consent, which was being given by their surrogates, obviously, and not by the patients, could be staged and readdressed so that people could say no more than once. And the first patient who came into this study is one that we've published. It was a 38-year-old man, and he had a very severe head injury in an assault, and his brain filled with blood and was compressed, and the brain stem was compressed through the center of the vault of the skull, and he came in with a very, very low level of function. The Glasgow Coma scale is the typical way people are measured after severe injury, and a Glasgow Coma scale of 3 means that you're alive. It doesn't mean that you're actually doing anything. You don't have to do anything to get a score of 3. He then recovered to vegetative state, and by 2 to 3 months had transitioned through evidence that he was tracking with his eyes to minimally conscious state. He was in a rehab center for more than 2.5 years, and over that period of time, his highest level of function was that he could, in fact, respond by looking at printed yes-no cards about 30% of the time to give you an accurate response. Am I pointing up, or am I touching my nose, or to those types of questions. But we knew something very interesting about this patient which had intrigued us, and that was that several years earlier we had studied his brain using fMRI presenting passive language stimuli. And so in this study done with Joy Hirsch at Columbia, we had narratives, personally meaningful stories that were read to patients. And when this patient heard a personally meaningful story, he activated all the parts of the language system in the brain that normal subjects did. But unlike normal subjects, when that narrative, that audio, was turned backwards in time, he almost activated no areas except for the earliest parts of the auditory system, whereas the normal subjects typically activated both parts of the brain equally, if not more, for the more unfamiliar reverse stimulus. And we thought maybe this was a sign that a very important, salient, emotionally evocative stimulus would ignite his brain and activate it, but for the most part, it was an inactive structure, and that was supported by having measured his brain metabolism globally as reduced to 50% of normal, which probably is roughly what I was showing you in the off state of the patients who responded to Ambien. So with this information, we had the sort of case that made sense to us of a brain that showed us integration across many areas of the brain, very low baseline activity, and the possibility that if the central thalamus were activated, that more behavior might come out. And in fact, we enrolled this first patient into this study some 4 years after the images I just showed you, and placed electrodes in the central thalamus. This was done at the Cleveland Clinic. And he went through a trial which included 4 months of assessing his behavioral level in rehab, surgery followed by 2 months with the electrodes remaining off, followed by 5 months of testing different electrode stimulation parameters, and then finally he went into a 6-month, 30-day on, 30-day off, blinded, alternating crossover trial. And in the initial phase, we looked at the Coma recovery scale, which is one of the standard measurement tools, and I've broken out these subscales into words here to explain what they are. And this subscale, the oral motor subscale, the top score is intelligible words. You have to say 2 intelligible words on the assessment, otherwise you get a 2 instead of a 3. Although he occasionally could mouth words before this trial, he never on confrontational testing could do that before or after surgery, but once exposed to brain stimulation during the titration period, consistently was able to do it, and we no longer could use this scale and we had to go on to a different scale. The sustained attention scale here measures the ability to respond consistently, and it's a very low bar. The top score here means that you don't fail any more than 3 times to respond at all. And he did much better once being exposed to brain stimulation during the titration phase, but not consistently able to do this. And finally, the functional object use top score of the motor function scale is to demonstrate using an object, say brushing your teeth, combing your hair, but not necessarily to do it, pretend to drink. This was not something he could do before or after surgery, but started to come back right away during the titration trial, although this was inconsistent. The problem we had was that when we got to the 6-month crossover trial, which is now the next data coming off the slide, it's not shown here, we had the problem that for every single behavior that we were measuring before being exposed to stimulation, his values were either he had not ever shown an example of the behavior we were now tracking, aside from communication, or it wasn't even testable, which is, in a moment I'll explain to you the case for oral feeding. Nonetheless, we were able to show that on versus off stimulation, he could respond more consistently and he could do more complex motor movements. The effect on communication was so strong by the time the titration trial ended that it didn't matter whether he was on or off brain stimulation. He was now able to communicate consistently. And in fact, he was able to do this consistently, not with a 30% here of yes-no cards and a patched eye, but through spoken yes-no or head nods and obvious gesture. Similarly, this motor scale I just described to you was essentially ceilinged, and he could do this whether he was on or off brain stimulation or not. But the most important and significant thing was oral feeding. And there was no pre-stimulation metric for oral feeding because the patient had remained tube-fed for 7 years. And it was halfway through the titration period of being exposed to several hundred hours of brain stimulation that the therapist noticed that he was awake enough and alert enough and able to clear the secretions in his back of his throat well enough to try to safely feed him. And he was advanced on feedings, and by the time the crossover phase started, he was having 3 meals a day. But it turned out that he could do that essentially all the time when he was on brain stimulation, but less than half the time when he was off of it. And what happened actually, and I'm not going to show you the data, is that he would hold this for about 2 weeks, and then he would become unable to respond sometimes, or he would put food in his mouth and not chew, and he would have essentially then been failing to be safe to feed, had we not, at the end of this trial, put him back on brain stimulation, after which he remained able to feed 3 meals a day, finishing meals within about 15 minutes for each feeding, which is a major change for those who have experience taking care of patients who are severely brain injured. So we saw lots and lots of changes in this patient: recovery of communication, recovery of limb control, recovery of arousal and oral feeding, similar to the kinds of things I showed you in the ambient responsive patients, and similar, if not as dramatic, as what you saw in the beginning with Don Herbert. So this gives some hint of this, but the most important thing to know, and this is my last slide, is that the generalizability of any of what I've just shown you, particularly the brain stimulation work, is completely unknown. This is the goal of future work. We have to figure out the logic and the rules and the selection criteria for when we do fMRI communication experiments, for how we sequentially investigate pharmacologic therapies, for when, if in the future we're able to identify patients who might benefit from DBS, we select them into these trials. There's a lot of variation in structural brain injury of all types, and that will determine undoubtedly who might respond and who won't. And as we go forward, we have to look at each stage of this and understand the risks that we're exposing individual patients, subjects to, and what our potential goals of care or therapeutic investigation might be, and whether they're proportionate. And my colleague Joe Finns has written several very important and thoughtful pieces on this. And I'm going to leave you with those challenges, and I'm going to thank my collaboraters at Weill Cornell, particularly the group Neuroimaging. John Victor, who's here in the audience, is a neurologist and a mathematician, and John has been working with mathematicians, and we've been working with the help of the Schwartz Foundation with a postdoc, John Drover, to try to build mathematical models that could help us gain insight and deeper insight into what we might see in these brain tracings and how we might go from real measured observables, of which we are getting lots and lots of very interesting pieces of data and insight just from the biology, into models that might be able to predict similar things and help us dig this out at a deeper level. My colleagues, particularly at the JFK Johnson Rehab Center, Joe Giacino and his team, have been essential to all of this work, and of course the agencies that have funded us, and thank you for your time. I'm sorry I ran over.
Thank you very much. We do have some time for questions, and we welcome them. If possible, if you can get to the microphones that are in various locations. How varied are they, actually? Yeah, sure, absolutely. Just come to the front of the room, I guess, is the only place where they are.
Choose this mic.
Yes, it's live.
Hi, Dr. Schiff. Thank you for coming here today. I've emailed you a couple of times.
Okay, I have to apologize. I don't have an
okay.
administrator, and I am deeply behind. And
It's
I
okay.
apologize to anybody out there who's watching this.
I just, my 36-year-old brother has an hypoxic injury as of September 30th of '09. He was brought into a hospital on Long Island where the nurses had begged me to get him out of there because they said it was just a small community hospital, bump and bruise. I was told my brother was in a vegetative state. I could put him in a nursing home or hospice and withdraw care, which that was the medical team. The neurologist had said, no, he's young. So I got him out of there and I got him to another hospital on Long Island, and they did a brain SPECT scan, and it showed that he had a diffuse hypoxic injury on a ventilator, feeding tube, the trach, and December 1st, we had a palliative care meeting. Again, the word nursing home. And I know that I've read articles from you that over 300,000 individuals in a minimally conscious state are in nursing homes, and I knew that that was not the place for him to be. I had a woman come in from the Shepherd Center in Georgia to come and look at him. Unfortunately, the doctors had given him some Ativan right before that, so he was very lethargic. But he was raising his eyebrows, closing his eyes tight, moving his hand. And she said, you need to use your resources in New York. But we didn't know those resources, and neither did the discharge planners. So then he started to talk. He said, wow, when I told him we raised $5,000 at a fundraiser. I was rubbing his foot. I said, does this hurt you? He said, no. He was able to answer simple yes, no questions with his head appropriately, laugh at very personal jokes between him and I. And I couldn't find no place, nobody would take him.
I understand, and you know, this is a huge issue. There is no healthcare delivery model out there that's accommodating this problem, and it's not really fair, because the amount of time and energy that's being spent rescuing people in the acute phase. Your story, you know, obviously is one that needs to be recognized, and actually this is happening not just in the civilian population now, but veterans who are coming back from the war with severe injury. Everybody who's discovering this through their family members discovers that, you know, there's no systematic structure and infrastructure to deal with it. Obviously, you know, and I agree, he should be getting people working with him, trying to establish communication and trying to work with the available tools, and because he's conscious, he's able to communicate.
Well, he was, and what happened was his insurance company denied him, and the medical director was a pediatrician that denied him getting acute care. So now he's in a hospital in Queens, and he had a seizure and spiked 107 fever, and now he's completely flat. So we don't know if it's just a little setback or if we're going to get that back, but I just, you know, reading all your articles, and there is up for Senate review that hospital discharge planners from the Senate should evaluate anybody with a brain injury insult to a rehab. And I'm just hoping that we can change, instead of sending them to nursing homes, that we can find a way to have people like you.
So there have been 2 national committees that have made recommendations on this general issue. One was the Mohawk Committee, which was put together by the U.S. Congress Congressional Brain Injury Task Force. The Mohawk group, and I was just at the International Brain Injury Association meeting on this last weekend. It wasn't even this weekend, it was Saturday, where this was, you know, brought back out. The Mohawk group involved neuro rehab people, neurologists, neurosurgeons, and essentially laid out a comprehensive idea for specialty centers around the country that would be involved in making initial diagnostic assessments and then providing essentially a rope to work. So if we don't have an infrastructure to put everybody in a specialty care center now, but at least there could be centers sited around the country that could do evaluations, that could work with nursing facilities, skilled nursing facilities, subacute rehabs, other places that didn't necessarily have the expertise, and then when patients changed or they had a diagnostic issue, they would come back and be reevaluated. This is a legislative issue. My colleague Joe Finns is really the policy person of our group, but I you know, I'm sorry. I mean, this is really not the way it should be. It's not the way we treat other problems in medicine that don't have the sort of intimate impact of whether or not somebody's conscious and, you know, fending for very, very vulnerable patients.
Right. Or at least getting to hospitals, like, you know, he needs a repeat SPECT scan. They don't have that at this hospital. I asked the neurologist, well, what about the ambient study? Because I know Moss Research is doing it.
Right.
Oh, I don't know about that. So I'm glad that you're here and bringing an awareness to this situation. You know, it's sad for me. Yes, my 36-year-old brother has this injury, but I'm hoping that, you know, more lectures that you have, that we can make the change. So thank you. Appreciate it.
Thank you.
Hi, Dr. Schiff. Thank you for the very good lecture. Do you know if, or you have tried any neurofeedback strategies that could index patients' cognitive?
I have not. My colleague Joe Giacino and his colleagues, he's now at Spalding, actually, at the Harvard Medical School, they're interested in this, and we're going to start working on integrating assistive device trials into some of the work we're doing, hopefully, over the next couple of years, and we're interested in it, but I haven't really done any specific work in that area.
Hi, thank you for coming today. The talk started very broadly about consciousness and quickly focused on the central nucleus of the thalamus, and specifically, you know, your lab's efforts to probe that as far as its role in consciousness. Typically, you think of consciousness as a very diffuse process. We don't know what causes it. Is this just? Do you think that this is really the best lead as far as the anatomical focus on what it does that, or just where your lab's focused and
Well,
we want to talk about today.
so let me re-summarize my talk for you.
No, but
It's because I intentionally sort of wanted to start with consciousness as a black box, right? So consciousness really starts with observations of behavior, right? And what we have now is the ability to go to the bedside and do lots of very careful behavioral assessments, and we can identify small signs of consciousness that may help us get from vegetative state to minimally conscious state. And then if we can talk to somebody or they can gesture and have some reliable yes, no, then we can use standard neuropsychometric instruments or other behavioral assessments to kind of take us from minimally conscious state forward. The problem I began with was if we don't have gesture or verbal communication, then we have the problem of making an assessment of what is cognition within that gray box. And the first step forward in our instinct and our reflex today, I think, is to use neuroimaging. And I tried to show some of the examples, which I think are the leading examples now of how, using tools of fMRI, we are taking the brain as a bigger black box so that can speak to us through wherever it happens to activate, supplementary motor area, parahippocampal gyrus, these other areas that you saw reporting spatial navigation or motor imagery, and give us some response. But that's going to be a tricky process, and it's one that if it doesn't happen, or if it happens inconsistently, we have to think about failures of consistent responsiveness. The Ambien story leads us to what is a much larger circuit model that doesn't just involve the central thalamus, but involves the frontal cortex, these areas called the striatum pallidum. And the thalamus is no more important than the cortex, but without the thalamus and the cortex, there is no consciousness from the point of view of the neurologist, because we view consciousness primarily as an expression of the corticothalamic system. Now, why the central thalamus playing such a role? Well, it turns out to have a special anatomy, but it's only special with respect to how it helps to organize the cerebral dynamics of this entire structure. And to some extent, it becomes replaceable. And it's not the only method, but you'll find that almost all of these methods, if conscious levels change, they change at the cortical level and the thalamic level, and this part of the thalamus is going to report those changes because of this geometry of its connections. I would say I focus on the central thalamus not because it's going to explain consciousness to us, but it's practically a very economical choke point for manipulating states of consciousness and understanding some aspects of it. But in fact, the EEG measures cortical activity. The PET scans I showed you measure brain activity globally. And of course, the contents of consciousness are certainly not going to be revealed by the activity of this little structure. So how's that for an answer?
Of course, of course. Thank you.
Sure.
Thank you very much for your talk. I was thinking about if you have tried resting state functional connectivity, and if you can please tell us about the role of the precuneus in consciousness.
Mm-hmm. So we have. In fact, for most of the patients that have come through, we've acquired resting state data, and Henning Voss is the MR physicist I work with at Cornell, and we found some interesting things in that. Some of them are published. We found some correlations of structural injuries removing pieces of resting state networks. We found some other stuff which isn't yet published, so I won't preview too much of it, but we have actually found some interesting changes longitudinally as patients recover that are reflected in resting state and correlated with other measurements, not just MR-based measurements. And the second part of your question, I may have just lost it, was?
The role of the precuneus in consciousness.
Precuneus, right. So my colleague Stephen Lauries has emphasized the role of the precuneus in recovery of function in medial parietal area. And I think, clearly activity in the mesial parietal region indexes brain metabolism and recovery of function to the extent that that's causal to the recovery of consciousness. I'm going to sort of remain agnostic on that. I just don't know. But we do have one finding that's a little interesting in this regard from a patient who also is well known. His name is Terry Wallace, and he spontaneously recovered consciousness after 20 years. And in another work, which I didn't show today, we looked at the diffusion tensor imaging signal in his brain and found that areas in the medial parietal region had shown changes, and they continued to show changes from the time he sort of regained responsivity and speech and over an 18-month period that we studied him. And it's interesting, and we're not exactly sure what to make of it and how it would be causal to this story, but it's clearly the leading area of resting metabolism. It's a system that's associated with episodic memories and personal history, and Jerry Schwartz is interested in the role of non-conscious processing. And I have always wondered, and I think he and other people have wondered, whether this part of the story may have something to do with why the precuneus has that high metabolism, and it may be an index then of some recovery of other functions that are underneath the conscious level but important for organizing our behavior. These are all speculations. I really don't know.
I have two questions, if you don't mind. The first question is, if a generic was given instead of Ambien, would the results have been the same? Did you always use Ambien, or?
Well, we actually haven't been running studies to give patients Ambien. What we've been doing actually is studying patients who have come to us and told us, I take Ambien, or the families tell us, we give them Ambien and it works.
Okay.
And in fact, and some people in the audience know this, when we see patients and they've never been exposed to any medication, I don't start recommending Ambien.
Mm-hmm.
I actually have a longer list of medications that I think are probably safer and more likely to work, and we usually begin with that. And one of my colleagues and I are trying to write up sort of, our intuitive sketch of how we do this. But there's no rules about this, unfortunately, right now, because we just don't know enough.
Okay. On that order, the cocktail in the Don Herbert case where he had a cocktail of L-Dopa and 2 other ingredients, what were those 2 other ingredients, and why don't all doctors use this?
Well, we have no idea exactly what happened. And there's a long list of medications, and all medications have potential side effect profiles. And I think there are some sensible ways of thinking about how to do this. The 2 medications in his particular case were Strattera and Celexa, but there's no reason to believe that one out of that particular set of 3 was the one that did this. If I had to take a guess, it was probably the L-Dopa. And of course, it could have been that it was uncorrelated. This wasn't a scientific study. This was just, a probably more than chance correlation that he got these medications and this event occurred a few weeks later. I think the other thing I see a lot is, we don't follow patients and treat them. This is a research program, and when I interact with a family, it's always through a physician or trying to get them to have the physician interact with us or make sure the recommendations are being followed, because you can't sort of tell people try this or try that.
Yeah.
They could have lots of side effects, and it could be very inappropriate for an individual patient to be told to take this medicine or another. One of the problems out there, however, is physicians are too unwilling to try things for chronically brain injured patients.
True.
Because they'll say there's no data for this. Well, that's not exactly true. There are no class 1 studies, to support this, that, or the other, but that's true for almost everything you do in medicine, and it's just a species of neglect and disinterest, and I think that really has to change.
Thank you.
Okay.
Thank you. My question is about DBS.
Okay.
You gave us an example there of a young man and what his recovery was for, but you said it was a study. So I have 2 questions. One is, were there other members in that study, other patients, and what were their outcomes? And the second question related to that is, I understand that they are doing DBS surgery at Bethesda Naval Hospital, but there's nothing out of what has been done there, and I was wondering if you knew what was being done.
Well, more than I know. I don't know of anything going on at Bethesda Naval, but it could be happening, and we don't know everything. The study is ongoing. There have been other subjects, and when we're able to pull all of our information together and publish it, we will. And this is going to take a long time to kind of get this, from this kind of exploratory work to systematic criteria. But I'm hopeful that we'll keep making progress.
So I think we should thank Dr. Schiff and Jerry Swartz for this lecture. There is a reception upstairs in the gallery, right? Reception upstairs, to which you are all invited. Please join us, and this will give you another opportunity to talk to Dr. Schiff.